Thanks very much, John, and thanks for the opportunity from Mitch and CSRC to explain to you today what we've been doing for the last 3 years. As John said, I'm not quite sure what, being from England, what a slam dunk is or how that fits into the sort of basketball analogy. I understand Southwest Airlines now, having flown Southwest, so... Just a disclaimer, the views expressed are my own and or those of the CSRC, Informed Consent in Cardiogenic Shock Trials Working Group, and shouldn't be necessarily seen as the views of Abbott, and I am now a full-time employee of Abbott. I feel like I'm teaching to suck eggs when I show this slide. Everyone knows there are barriers to research in cardiogenic shock, and we're trying to balance up all of these things. The fact you're in a highly acute setting, in general. Of course, acute decompensated heart failure may be subacute, but generally speaking, AMI shock is an emergency. There's the practicality of gaining consent, the extent of a patient actually being informed, even if they do undergo some form of consent procedure, and of course the risk. And there's the risk of the condition they have, the risk of waiting, and will that manifestly affect the outcome? Again, I'm retreading things that I think everybody in the room probably already knows. There are lots of problems with randomized controlled trials and evidence generation in cardiogenic shock. You can see this table here on the right-hand side from Holger Thieler's review in the European Heart Journal from a few years ago. You can see that many of these studies either failed to meet their primary endpoint and showed equipoise or didn't manage to recruit enough patients. There are lots and lots of reasons for this. Probably we have a small number of patients fulfilling the inclusion criteria for the studies. The varying interpretations and definitions of shock, which we really hope that the SHARC definitions will overcome, and Naveen's done lots of work on phenotyping shock, because I think probably many of the problems with these trials is a very heterogeneous mix of patients in them. Of course, there's an overlap with other clinical syndromes, ambiguity of results, and of course there's the act of commission. Interventions are emotively employed when patients could be randomized. Then, of course, there's the issue of informed consent. You probably wondered when I was going to get to that. I'm very grateful to Ernest Spitzer for letting me take a slightly blue picture of one of his slides from the ARC-3 meeting yesterday. This is not about shock, it's about acute myocardial infarction, but it does talk about some of the similar barriers. Lack of competence, that's, I hope, the patient rather than actually the clinician. Patients in pain, having received opiates or drugs, reduced level of consciousness, and of course, anxiety as well. Interestingly, these are two studies here, and you can see on the left-hand side, patients' experience of being asked before the procedure, so just asked if they want to participate, and they all feel very positive about that. But patients who then are asked to sign something afterwards, they quite often object to providing informed consent post hoc, and I think that is a truism that we already know, but it's nice to see there are data that support that. Having practiced in the National Health Service and having taken part in lots of STEMI trials for both lytics back in the day and primary angioplasty and also shock trials, coming to the US and being presented with the legal minefield that is the EFIC and the research around informed consent was really an eye-opener. Many of the studies in Europe require only assent, which is a kind of tick box exercise, and signing a form later on. There are many people in the room who know much more about the EFIC consenting problem. Pablo Morales is over there. I'm not going to go into this in enormous detail, but as you know, the common rule is a very important part of this. We have to be very careful about just deploying EFIC, the exception for informed consent, willy-nilly, but it can be used in life-threatening situations, as you can see, where available treatments are unproven or unsatisfactory, and informed consent is impossible or cannot wait. Of course, the problem is that's something that is up for debate and is not exactly a clear-cut scenario. So I'm just going to summarize what we've come to as the sort of the output, if you like, of the blank canvas that John and I started with 3 years ago. Clearly, networks are already in existence. We've got several representatives of shock networks in this room. The NIH and the FDA have a key role, as we've heard already. The NIH in 2018 was very keen that patients who take part in their sponsored studies should go through a single or centralized IRB. And of course, we had the revision to the common rule, and we heard earlier on that the FDA is in process of taking comments on a document that will make this mandatory for all these kind of situations. We rather I won't say stumbled across the idea of a centralised IRB, but it came apparent as we spoke to people who've worked in this space, not necessarily in shock trials, but in other emergency settings, such as acute myocardial infarction, acute stroke, and various other areas, that a centralised IRB could be the answer. And of course, the final part is thinking about the consent process and how that might be reformatted. We had a whole working group think tank on centralised or single IRBs in September 2022, and I'm grateful to Rebecca Torgerson for allowing me to pinch a couple of slides from her deck. We've heard a lot already today, if you were in the morning session, about single or centralised IRBs. One of the issues is they may lack subject matter expertise, particularly when it's complex medical conditions or complex trial and procedure protocols, as inevitably cardiogenic shock trials will be. They can seek expertise, but that may cause delays or inefficiencies. There's also the issue of local and unique populations. These are some of the other areas. A single IRB, you need special documentation, you need to review the needs, respect to study, trial and expertise, and the logistical implementation must not be overlooked. So how do we implement this moving forwards if you're going to have a centralised body of expertise in a single IRB? Well, speaking to some of the people who work with and in the setting of centralised IRBs, one idea that was put forward was that members of the CSRC could be co-opted to be that remote body of expertise to inform a centralised IRB if there is a centralised IRB that is not prepared to take on the work of cardiogenic shock trials per se. I'm grateful to Neil Diker, I don't think he's in the room, who has been very, very important. He's a cardiologist and he has a background in bioethics. Again, I borrowed a couple of his slides here. These are really the four options for the consent process. A full consent from a patient or a surrogate, otherwise no enrolment. That's been done for years in acute myocardial infarction research, including shock research, but probably that's led to enormous selection bias, and if we're actually honest, it's a bit of a charade. Most of these people are not really capable of giving informed consent. Secondly, context-specific consent process for full informed consent. That's kind of more honest if we design it for the context, and I'll talk a bit more about that context in a moment. But you do require the IRB to agree to that. There may still be some selection bias, and you do run the risk of limited understanding, especially with short-form consents. And then we've got the two EFIC options. EFIC with involvement, where you tier to capacity. That should minimize the selection bias. It's the most context appropriate, but again, here's where the regulatory issues come in, and there are EFIC hurdles regarding community engagement especially. EFIC as default is the thing that is generally inconsistent with patients' or surrogates' preferences. It can be difficult to justify as to IRBs. And again, these are rather emotive headlines that have come from the US press, from the Washington Post. You can see on the right-hand side, this is a decade ago. And from the left-hand side, from the American Journal of Bioethics, Americans should not be on a game show in US emergency rooms and ambulances. It really polarizes people, this whole debate about EFIC. Let's talk very briefly about the capacity for consent. This is the Sky shock state. I think it's fair to say, going down from the top, people with E, D, and C are not capable to consent. B, maybe. A, possibly, probably. I think a conservative estimate, maybe 20 to 30% of patients are really capable of consenting. But of course, we don't have an adequate mechanism to stratify those that are and aren't suitable. There are a variety of mini-mental test scores, if you like, cognitive state awareness tests, but none of them have actually been trialled in cardiogenic shock. I'm just going to finish by talking about the matrix and this context specificity. Thanks to Mitch for this. He finally explained what he meant by us, but this is a synthesis of all these outputs and how we should be thinking about the consent process. What's the clinical scenario? Will the delay manifest in patient harm? What's the status? Is there a surrogate? And is it a novel device against standard of care, approved device against standard of care, or is it device against device, which is either approved or not, or unapproved? And of course, all of those may require a different level of consenting. I'm going to skip straight to this, and I'm grateful to the Shark Group for all their work, and also this is their modified or hybrid AFIC consent. This is what's being used, I believe, in Protect 4, and this is in the Shark document. Again, this is a framework for how we might go about a hybrid EFIC. May not be suitable for all of those trials, models that I described, but certainly for some of them. I'll skip straight to the end, I hope, before I run out of slides. There are some open issues. Expertise is an issue, adherence to relevant statutory obligations, EFIC and abbreviated consent, which patients, community consent, integration to networks and shock centres of excellence. And of course, one thing we haven't talked about is regulatory considerations and harmonisation with international partners. I'm going to stop there. I've got to thank everyone who's helped us on this journey. There's a lot of people who've come in and out and shared their expertise with us. Grateful to all those people, and if I've missed anyone, I do apologise.